Wait, am I on it? Am I on it?
Are you on it?
They didn't even record, like, faces.
It's going?
You gotta, like...
Okay. Gotcha.
Are you good, camera operator? All right. So, the first thing we're going to go over, and I'm going to give this to you guys later, is when we're talking about the ASAM. So this is real life clinic stuff. On your ASAM, I've been noticing a pattern. Thank you. I've been noticing a pattern of in the dimensions. We're talking about the client this, the client that, the client reported, da 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 da. I want to reiterate that it's not just about what the client says or reports, right? It's also about what you are observing in the intake, during the assessment. So I have this. I will make copies of it for you because it's really well written, and I want to point out some verbiage that that can kind of help you include your own clinical impressions into this. So, before I move on to that, clinical impressions versus opinion, versus your opinion, what sets that apart? Christina, what sets that apart for you in your writing?
So, versus opinion. Clinical impression is... Yeah,
That's okay. Scarlett, what do you think?
Clinical impression would be more like, how do I say this? Putting, like, clinical impressions versus what?
Your opinion.
Opinions are bias.
Okay.
Clinical impressions are what you actually observe.
So how would you rate that?
I don't know, I'm not allowed. As evidence by?
Hold on, I'm not to you yet, Jonathan. Maurice, take it away.
AEB.
How can I tell in your writing it's your opinion versus your clinical impression? I think, I believe is what?
This patient is whatever the opinion is, whatever the...
So if you write, I, Maurice, think that this client is blank, that's an opinion.
Yeah.
Okay. Dan.
Okay, I'm gonna use a methamphetamine addict as an example. He comes and sits down and he's got pockmarks all over his face. It's my opinion that he's on methamphetamine. His actions, though, show me something different. He's jittery, he's shaking, he's walking around, his pupils are all dilated. I'm gonna give an impression that he's probably on some kind of upper. Whereas my opinion, just seeing him on the street, could be, oh, this guy's probably a method.
Very good.
Stimulant, not up.
Right.
Stimulant.
Stimulant.
Donna, what about you? You already have the answer.
Yeah, we already have the answer now, because that basically,
Blurted it out.
that clinical impression is as evidenced by observed, this was observed, physically observed. You can't go with what your gut impression is, and like I had a person in my office this morning who nodded out like 8 times in the first 10 minutes that he was in my office. So my clinical impression was that the person was probably over-medicated or probably had taken some substance into their system before they came to dose. So, yeah, that would be an observation.
Good. Angela, how about you?
I must concur with Donna.
I knew you were going to say that.
So, opinion is what you think based on subjective information. Clinical impression is exactly what you're seeing that's based on objective stuff that can be measured.
That can be measured. Very good. So, the whole point of your psychosocial, the first 8 pages, is just information gathering, right? it asks very specific questions about family, about past use history, because you are formulating your clinical impression in your ASAM as to why or how this person came to sit in front of you, right? So for Dimension 1, acute intoxication and withdrawal, this says, client reports current daily use of heroin and methamphetamine. Client also reports several lifetime overdoses, including heroin, including 2 recent hospitalizations earlier in 2018. Okay, right there, that's just client reporting, that's information gathered. And then they go in to say, client is observed to be progressing with withdrawal complications, including self-reported anxiety, appearing to become sleepy and sweating in her facial area during this interview. So did you hear it? Not only did the client say all this, and I put that in there, her client report, but this is what I observed during that. This is what so a good liner is client is observed to be blank. So it's a helpful thing. Client is observed to be jittery, nodding out, tired. Like what you see is also important to add in there, right? So if you're talking about Dimension 1, acute intoxication and withdrawal, and they're like, yeah, I'm good, right? Or I'm not in withdrawal, and they start throwing up all over your office. If you just put the client reports they're not in withdrawal, and you leave that, you're not giving a very clear, full picture of what's going on. So client is observed to be vomiting profusely all over the office, however you need to say whatever you need to say, right? Another example in Dimension 3, Dimension 3, behavioral, emotional, cognitive. Client reports no current or lifetime history of behavioral, cognitive, or emotional conditions or complications that require immediate mental health services or that could likely interfere or distract from substance abuse treatment. However, client cried and was observed with sad affect when discussing loss of 9-year-old son. So again, not only are we talking about the report of the son had passed away, the 9-year-old son had passed away, but this counselor put in there the report of client cried and was observed with sad affect. So again, utilizing that observed with, that's a good way to do it. Another one, as evidenced by, which however way you want to write that works fine, okay? And then in the last, and like I said, I'll give you a copy of this. In the last Dimension 6 recovery environment, it's a very long paragraph about courts, different stuff this client's going through, unemployment, all these different recovery and living environment factors. But then at the very end it says, the structure of probation and related services in conjunction with MMT, what we do, could lower the risk level associated with her recovery environment. So even in that area, this counselor isn't saying by them being involved with probation and methadone maintenance, they're going to be cured, they're going to be recovered. He was just saying that all that combined together is a good place for this person to start on their recovery. So, any questions about that? Christina, does that make a little more sense?
What were the two, it was opinion versus fact, or
Opinion versus clinical impression.
opinion versus clinical impression? So the clinical impressions that you were reading were the fact that they were reporting that they're fine. And the opinion was that, okay, but yeah, they were crying.
Well, no, not the opinion. So if this counselor wrote it as, client reports they're fine, but I think they're not because they're crying, that's opinion. Client says they're fine, but I believe them to not be, that's all your opinion, right? But if you put in, I observed that they had a sad affect or they weren't feeling good, you're putting in an impression of what you also saw along with what they reported. Does that make more sense?
Okay, So what you were reading was, not really opinion anyway.
Right,
Okay, so we never write opinions.
correct.
Okay,
I don't want your opinion.
okay, so you were just telling us to distinguish,
Yes.
Really long.
but we never write opinions.
Yeah, I don't want your opinions,
Okay.
because that really can start turning your writing into, I am the expert, I think, I believe, I feel, I saw, but you don't know all that for a fact or not, right? And that's why I didn't say fact. It's not opinion versus fact. It's opinion versus your impression of what this person is really going through. It's also known as your clinical judgment, but a lot of people don't like to use the word judgment, because then it sounds like we're judging. It's used wrong. I mean, we utilize that wrong. It is a judgment. You're getting all the facts together, you're gathering all that information to say, this is gonna help or hurt them in the long run based on my master's, my background and knowledge of all of this too. Make better, so yes, no opinions.
It's objective
No
versus
moral
subjective.
judgment.
Objective versus subjective.
Just remember, only write what you see and hear.
Right.
And smell.
Just
Nobody
the
cares what you
facts,
think.
ma'am. Just what you see.
Yeah, I got confused because you had us do the exercise.
Yeah, I know, I like to, because I want you to remember, no matter where you work, no matter where you're at in the clinical field, it might feel like you're allowed to have your opinions on an area. They never hire an expert in a field on their opinion. They hire them on the tests that they take, the diagnosis that they do, and what they formulate for them. So another example of that, my old supervisor was a forensics person, fancy word after that. They would not hire her to come in and say, I just know all of this, I have this background, so I will tell you this person is, whatever, did this. She had to do a multitude set of assessments and tests, gather all that information together, and formulate her impressions of that client, right? That's the same thing we're doing on a little smaller scale, right? Scarlett, make sense? Question? Okay. Yeah. Maurice, you're having an emotional reaction over there.
He always
What's going on? Let's talk about that.
Let's talk about
Let's
that.
dissect this, Maurice. Let's dissect it.
Yeah, I mean, yeah, the opinion part, that's the thing.
What about
It's the
that?
wording.
It is the wording.
The wording, yeah. So it's a tricky thing.
It is tricky. I don't know if a lot of your guys' master's programs taught you that, writing and research writing doesn't always translate to your note writing, right? Anybody feel that after being involved in work? Yeah, it's a little different, right?
Yeah.
But even while you were in your master's program, when you did research, it wasn't like, I believe that this is a thing. It was, this writer found this information through this person, and I formulate all this together to have my own research on it. Okay? So yeah,
So I'm
that's,
glad you clarified that. I'm glad we're talking about this.
yes, because,
I can see how, like, when I do my exams, the intake, how you get into a certain habit of writing, the way you write, and do things, and I can see how now I need to go back and, kind of make more the clinical impression part, rather than just the facts of, history and all of that, but like really look at the clinical impressions.
right. Because the other piece to this too is, persons in addiction or working on recovery are not the most reliable historians of their own story, right? So they can tell you life's been good, nothing happened, yada yada, and then your assessment or your ASAM would be like, oh, they're good, like everything's fine and cool. But the more you dive in, and why we ask the specific questions we ask in the psychosocial is so you can formulate that impression of what's going on. So let me ask you guys this. There on the psychosocial, it asks about family history use. Why do you think that's a question? Why does that even matter? Angela, why do you think that matters?
It develops a pattern.
You can see patterns in that?
It develops a pattern, and then it also directs you to ask, well, when did you start? Who did you start? Is there a connection between your use and maybe dad's use? Did you guys party together? Did you guys used together?
Right.
So I mean, it develops a gateway for more information, and it also gives you an understanding of, well, this is a generational problem as well.
Right.
The generational piece. is-
Generational piece, okay?
Normalization, it's not, people will say that it's not really such a problem, or I'm here, they compartmentalize their
Right.
use, like I'm only here to take care of this drug that I'm using, not the other four.
Right. Why were we talking about those? Dan, have you ever thought about that question for you? Like, what does it help you formulate and?
Yeah, it does, because I'm gonna give you the example of two addicts. One of them, she broke her knee or something, and they put her on oxycodone, and then she really liked them, and then she went from there to street heroin. There's a huge difference between that and somebody whose grandfather was an addict in Coyote and used to sell back in the 40s, and then the dad sold, and then he's selling now, and his son is selling, and it's been generational. It's been a Chiva has been this big cultural thing for generations. There's going to be a difference in treatment in the two of them.
Right, and I heard what you just said, generational and cultural is a piece to that. Maurice?
Well, and you and I talked about this when it came to the higher, you gave me the assignment, I don't know if you remember the assignment,
Yeah,
About
all of those.
the
I remember all of those.
the
Yeah.
genogram.
Yeah.
Yeah, so like the genogram, it's like a shorthand genogram, just
Mhm.
like a peek window, like looking at like the impact or influence or even the value, because you get a lot of guys that like, they don't, their father died or mother died or mother uses or whatever, and then you could see the emotion, and whether they value family,
Right.
whether it's something that they want to talk about or whatever, but so I could see how family history is very important,
Right. And at the end of that ASAM, we wouldn't necessarily have to put, I formulated this thought that dad used and this happened and that happened because of this and now this person is here.
Right.
But it's a piece of putting it all together.
Yeah.
Scarlett, Christina, like, what do you guys think of that question, family history?
It can, make an impact on their recovery,
In
their
what way?
living environment.
So I'm hearing their current environment, generational stuff, cultural stuff, normalizing it, anything else?
Recovery living environment, because if.
Their living environment?
Yeah, because so Christmas, you might be away from them, but you're gonna be around the family for Christmas.
Right.
Or, can you really get away from your sister or your cousin? It's such an impact.
Yeah. Christina?
And I know it's a big deal to them, whether or not their family uses, because I see that they stop for that question. I ask it, did your family use, and they're like thinking,
Mm-hmm.
should I answer that right or tell the truth or not? I mean, like 50 to 70% do that.
Yeah,
Should I answer truthfully or not?
right.
Which brings up a point, now that you mentioned that.
Yeah.
I think sometimes we don't pay attention to that behavior.
Right.
And if we're not paying attention to that behavior, because you're right, I've noticed it too, but up until now, you mentioned it, I never given much thought, but
Right.
that's an important observation to put into number 6. It just clicked.
Right.
Now that you're talking about what we're supposed to be doing, that makes total sense to say, in the environment, when asked about family history, client was hesitant to give a response, or observe, being hesitant, or taking, an extra 30, 40 seconds to answer the question.
Right.
Appear, whatever. Because I think that is important, especially you're using homes as the example,
Right, and exactly like you're saying too, it's important because how can that then affect their recovery? Right, if it's normalized, it's cultural, it's generational, and, they come in here and we say, well, let's try something completely different, where you don't do that, and you step away from what has been normalized in your family, culturally around you, and now we're gonna do something completely different. That's a huge factor I think we forget sometimes for the people who come here, right? And so in your ASAM, just like Angela was saying, you don't have to put you know, here's all this background and here's why I think this, but here's as a counselor, as someone who works here, I can see a connect between that, and when I need to utilize supports, you know, I might at this moment now think family, who is the biggest support usually, might not be. And now I need to adjust how I'm going to work with them in their treatment, right? That's what I'm more looking for, in whatever word and verbiage you can boil that down to. The other big thing for me on that question, now this goes way outside of thought thinking, but nature versus nurture, right? How I got here, how and why, and was it my environment? Was it how I was raised? Was it those factors in there too? So that's a question. That's when I've ever looked at it, I'm like, nature versus nurture, environment, all that, or is it something else, or is it in the blood? You know, is it you know, when, what is that called when it's in the blood? Genetics, right? Genetics, thank you. Which is where disease model comes from. You know, so all this stuff, all the training you have and background thought on that, that's what you're tying together in that. That's how you create a clinical impression or your clinical judgment on, when I talk to this patient about, and they get hesitant about opening up about that, how is that going to affect us in our work here, right? And it could or couldn't, and how you formulate all that. Does that sound good? Mm-hmm. So like I said, I'm going to give you a copy of that. It's just an example. It's a more in-depth way of viewing your assessments. And the reason I want you to do that is because if you stay here working in methadone maintenance treatment forever, awesome. If you go somewhere else or you're independently practicing and you have to formulate a diagnosis, you have to think outside of that box of just dimension 1, 2, 3, 4, 5, 6. You got to look at the whole picture and say, whatever this is, if it's a mental health issue or wherever we're at, how do we work on it from here forward? Cool?
Cool.
Mhm.
Cool.
I'm just gonna add to that. I actually pulled away from doing that a long time ago, writing like that with a clinical impression, because of so many of the different trainings that we've had that seem to like pull us away from putting that in there.
Right.
So it's like, okay, and so that's evidenced by what, you know?
Right.
And so I'm like, so now I feel like I'm reverting back to where I was when I first came in, because I really did pull away from putting those clinical impressions in. And so I think that it's good to be able to do that.
Yes.
Because it rounds it out, but I actually did pull away from that, so it's, I don't actually know what trainings it was that pulled me back, but yeah, it's like there's just so many things that come down the pike over time.
Right. So let's talk about the elephant in the room. There's a time factor too, right? You guys have had to run through 8 different sections of the psychosocial. You fill out consents, you're meeting with someone who doesn't feel well, like I get the whole thing. So, you know, we do find ways to simplify and put stuff in there, but I'm telling you, if you can formulate your impressions in your ASAM, that it makes sense, you've looked at all those areas, your treatment plan is going to make a lot more sense, right? It's going to be way easier to not, it's going to be way easier if we use Christina's example and know that maybe this family or the embarrassment or whatever that piece is to it, if we either completely ignore that or we don't take that into consideration, we're going to miss out on how we can get to this person specifically, right? We tend to, because of our time, kind of put them all in the same, you know, they're from northern New Mexico and they've been using, and the stories sound the same all the time. But we got to individualize that, and that's what we do come back to, is person-centered, client-centered, what's going on with them, and then formulating that golden thread, right, throughout the treatment.
Awesome.
Cool. So the next thing I want to talk to you about is metaphors. Metaphors, therapeutic use of metaphors in counseling. Dan, you're shaking your head. What does that mean to you?
This is what it needs to be. Had a client the other day, beat Chiva, beat the heroin, but now he's stuck with cocaine. And I told him, you climbed Mount Everest and conquered it and took the photos at the top. But now you're looking at K1 and that's an even bigger mountain. I said, it's a bigger bitch to beat methamphetamine or cocaine, whatever it was, because you had methadone as a bat in this fight of addiction, but with cocaine, it's all up here. So now you've got to conquer K1.
I like that. Who else in here has ever used a metaphor in their therapeutic?
I used Dr. Seuss stories. I actually did that today. One of my, well, the one that I used today was about the fix-it-up chappie with the sneeches that have stars, and then the ones that don't have stars, and then the fix-it-up chappie comes, and the people that have stars get them removed because they don't want to be identified with these people over there. But that story is really about racism, but the way I used it today was the fix-it-up chappie. You know, that this woman had been collecting resources for her using partner to get him to go to treatment. And so I was like, well, you're collecting resources like the fix-it-up chappie, you're gonna fix him, right? So that he looks like what you want him to look like. And maybe instead of being the fix-it-up chappie for him, maybe you could be the fix-it-up chappie for you. So,
You guys like that?
you know, because it's like, I don't know if you know that story, but they're like all running through the machine trying to like get to some goal, but nobody's getting anywhere. So, yeah, and the other one is about the north-going Zacks and the south-going Zacks. Do you know that story?
No.
North-going Zacks and the south-going Zacks, they come through and they meet each other in the desert, and they have an argument. The first one says, I'm a south-going Zacks, and I always go south, and I don't take a step to the right or the left, so I'm not gonna budge. And the north-going Zacks does exactly the same thing. I always go north, I never take a step in either way, right? So they're both there, and they're like there forever, nose to nose and belly to belly, and they build the overpass over them over time, and life goes on, and the two of them are still standing there
Not
nose to
moving.
nose.
Yeah.
So that's about not wanting to change. So those are I love Dr. Seuss, he's my therapeutic tool.
Angelo, do you ever use metaphors?
I don't think so.
Don't
I
think
use analogies more.
Okay.
Well, yeah, I guess I do once in a while.
Can you think of one that you
Yeah,
do?
so when we talk about pathways,
Mhm.
I use like stuff like trails,
Okay, good.
stuff like that. I think that's probably the one that I use the most.
So if you're talking about the brain instead of saying like the pathways in the brain,
So when I say, well, I explain to you what the pathways in the brains are, but I use trails like I can remember when the trails you used to play on.
Oh my gosh, I did that this morning.
If you go back to that trail, it's still there.
yeah,
It might not be as clear, but it's still, it's still there.
yeah,
Well, I said, drug addiction, same thing. You have that pathway, you can develop all the skills you want, but that pathway is still there.
yes,
And that's why you have to be mindful of your recovery, because your brain is designed to go to automatic mode.
yes,
So go back to the pathway that's with least resistance. Kind of like when you were a kid, you went to the trail that got you home faster, safer, whatever you call it.
yes.
So that's the one I use most.
I love it.
Yeah, I did that this morning with the tractor trails that go behind the houses to get to the different fields. And I use that about how, same thing, how when you run over that for 100 years, and it's, you have a little grass hump in the middle and the tire
But they're
ruts,
still there, yeah.
right? If you start to try to do another field, you can run over it for a long time before you get to it looking like that.
Right.
Like the grass
Right.
stands right back up the next day.
And still trying to,
So we were talking about that this morning. with
cool.
one of my
I love it. Maurice, how about you?
I don't know if I use a lot of metaphors. I think the simplest one I use is, person says, well, I want to be clean. And I kind of make an analogy to the person wanting to go to Texas. You're telling me you want to go to Texas, but you're going towards California.
Oh, you
So-
do the whole, I want to be going, I love that one.
So like, how
That's
can we
great.
how can we get to Texas?
Yeah.
So, yeah, that's what I do. all the
I like
time.
it.
Nice.
So,
Scarlett, do you ever use metaphors? Not that you can think of one from that. Christina?
I'm not sure, does the rock thing count?
Tell me about it.
Okay,
Like putting it on the altar and everything?
Yeah.
I think so.
yeah, okay, so.
Share it with everyone.
I have a little exercise where I have a bowl of rocks on my desk, and I tell them to take a rock and put something they want to give up, and then into the rock, and then put that rock into the bowl on my little altar where there's fake candles and a little saying, positive saying, and then they let that go and put that into the altar.
I like it. What do you guys think?
Yeah.
So one metaphor I used to use quite often is when I would have counselors, well, you guys do, when I would have clients talk to me about craving, right? And like we're 6 months in and I still crave it, and I would talk about ice cream, right? Like I would say if I go to the doctor right now and they say, you know, Rebekah, your cholesterol's high, your sugars are too high, you're gonna have to stop. But that ice cream is not so great for you. Do you think from this day forward I'm never gonna want ice cream ever again? No, I love it. It's my favorite thing. And I would talk in that way because they would put the use of, like, you know, the understanding of my craving you will never get. And I'm like, craving is a thing, and the medication here doesn't just make it disappear, right? And then that would lead us into using, and use was fun. Like, it's not like you didn't do it because it was bad and hurtful, right? And normalizing that with them, because people, you know, always the clients I had always wanted to come in and be like, the medication didn't fix me. I'm like, it's just a tool. There's still so many other tools we got to work on, right? And the reason I wanted to bring this up is because people are actually out there researching metaphors in counseling. So this says, metaphors offer a communication tool for counselors to bring about the conditions for change and growth, and for linking fundamental development changes that occur in the counseling process. So my question to you is, how do you think this technique of utilizing metaphor would assist with development of your therapeutic alliance? What do you think? Donna, we'll go with you first.
I don't know, I think it takes, like, I'll just go with like Tractor Roads or Dr. Seuss. It just kind of takes it away from the sterile clinical
Right.
jargon
Yes.
that you do with the person. And that's why I like Dr. Seuss, because there's always these crazy little characters that are like bumping heads. But it kind of lowers some of the defenses, you know, because now we're laughing and we're looking at how ridiculous the underlying thing is. These two Zacks, you know, are got nose to nose, but like the whole world's building up around them. And then it really kind of, we get to a point where we can talk about, wow, if we don't change, the whole world will continue to work.
Yeah.
But I think getting back to the question, is just kind of takes down some of the walls, you know, brings some humor into it, and the stories stick with people. Like those little things, those little vignettes seem to stick with people.
Yes.
The little stories, because I can say, do you remember when we talked about the tractor road, and they'll go, oh yeah.
Right. And
So-
I think what you're saying too is it makes it doesn't, I don't even know if we can use this word, but simplifies the thought process of what they're dealing with, right? If you just sit there in your clinical jargon the entire time and say, oh, well, the pathways in the brain and da-da-da-da, even I'm like, I don't know what we're talking about anymore. And when we talk with our clients about this stuff, they haven't gone to school, they've lived their life, right? Dan, how about you? Do you think utilizing your metaphor of the mountain, does it help to build a therapeutic alliance with
I
you?
think it does. I use the mountain a lot. And then I also use a little bit of self-disclosure. I tell them, I pass by Dunkin' Donuts every morning at 5. It's open, but it's completely empty. There's nobody there. I could stop in real quick, grab 3, get out. Wouldn't affect my time on the road at all. I eat my 3 donuts, real happy, and go to work. I said, if I do that every single day though, I'm gonna end up with diabetes.
Mm-hmm.
I say, and I'm trying to teach them some CBT stuff. So without
Yes.
using any of the CBT jargon that they probably have no interest in, put them to sleep, I tell them I'm driving by, I see the Dunkin' Donuts sign, and that elicits a response in my brain, and I wanna stop there, but I have to stop that thought. And I have to just keep going, and I have to, I stop, I think about it, I observe, no, that's just a craving, I don't have to have a donut, and I put things in perspective, I don't wanna get diabetes. That seems to work with them better than the pure jargon.
Yes.
They get it, because they've all been there, they've, not necessarily with Dunkin' Donuts, but with something else. So it's just kind of a more down-to-earth way of talking to them
Yes.
that they really get.
Do you guys hear that and what Dan is saying too? Like, not only did he use CBT skill and coping skill and perspective and even health topics in that. Like, it's a way to do all of that by utilizing a metaphor instead of, getting up every day and thinking about use and da 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 da. So, Maurice, do you think that something you're Texas to California,
Yeah.
right? Metaphor.
Yeah.
Do you think that helps build an alliance?
I do. I really do. It kind of strikes something in like a chord in them. But I think too, for me as a counselor, it feels like a need for creativity. Because a brain is like you do this left brain stuff, and then it's like, okay, how can I do some right brain for
Right.
me? And then also, like you said, like it brings these ideas, these different approaches into like a very simple context,
Right.
like it's kind of like telling a fairy tale or telling a child a bedtime story before they go to bed. It's got these big ideas in there, but it's like it's a very simple, cool story that they
Exactly.
can play around with. So that's how it works for me. It's like it's that creativity part, because we do the left brain stuff so much.
Right.
And it's like, oh, okay, how can I bring more of the creativity, right brain, the metaphor of right brain? So, it's like, it's just that balance, as counselors.
I like it. Christina, do you think you build an alliance when you let them do the rock to the altar? Like, do you think that that's helping, or does it cause more harm?
I think it's helping. Well, what I think metaphors do is they use like a layman's term,
Mm-hmm.
and it kind of gets across better
Mm-hmm.
to the patient. And then also, what was I gonna say? There was a research project I did on Spanish-speaking patients, and dichos? No, dichos are like
Oh, like proverb?
proverbs. Yeah,
Yeah.
yeah. Proverbs get messages across better
Yes.
to patients.
Yes.
Yeah.
I really like that. Angelo, you with your pathways, what word did you use? Trails. Do you think that helps build a therapeutic alliance with them?
Yeah, because I've been doing that since I was an EMT. So one of the things that my EMT instructor taught us was that people are in crisis. If you try to explain to them a heart attack, they're going to get
Yeah.
So you always explain things.
It's happening right now.
Right, you always
Yeah.
explain things in the dumbest form you can. Not because they're dumb, but because even your brain under stress can't process that much information.
Right.
So it's something that I've been using for almost 20 years. So
Very good.
it works. Some people, it's like anything else. Some people love it, and there's always going to be helpful people going, so, I mean, I love it. I try to metaphor it as much as I can.
Mm-hmm.
Even like when people complain about the watering down of the methadone, well, they're watering it down. I'm like, no, stupid, it doesn't water down. I tell them, so the one that I used to like, I tell them, how you go to the restaurant, you have your tea's perfect, you drink half of it, and then the asshole waiter comes and just fills you up without asking you, destroys it, but the fact is, what you put in there is still in there.
Yeah.
It doesn't change anything. It just has more tea. That's all. It's one difference. That's all it is. It's more water.
I like that too.
And so, I think metaphors really, really work because when you go back to the dichos part, a lot of the Spanish language is based on old terms, even in English, the way we use words in English. because that's what works best.
Mhm.
That's where people connect. So like people say, get off your car. Well, that comes from getting off your horse.
Or get down.
Or get
Yeah,
down,
get
yeah,
down.
I use that.
It comes from that. Why? Because that's when we feel comfortable. Our language is our comfort. So if you keep it where it's comfortable, you get more success stories, I think.
And I wanna piggyback on what Marie said about, childhood stories, right? Because in this research, it talks about metaphor has been viewed as a constructive method for clients to make meaning of their experiences from as early as infancy to their current situation. Metaphors are defined as a transfer of meaning from one element to another. A metaphor provides a bridge between two concepts and it creates a new idea that transcends them. So, research, I found this fascinating because I just thought we did it just to do it. Like, of course, someone was researching metaphors and counseling. And so I really want to encourage that. I want to go back to what Dan said of utilizing different therapies like cognitive behavioral with that, because that's what the research is saying. It says the importance of understanding the use of metaphors in counseling process is supported by findings in cognitive research and psychological development. Cognitive research has identified the capacity of the brain to process concepts and perceptions across domains. And then it talks about metaphors as the simplest way to do that, so people not only gain the skill you're trying to talk about, but just like Donna said, can hold on to it, right? So I think it's cool. I think it's a cool technique. I think it can very easily be utilized in what we do. I think I would encourage you guys to think of more things, think of more metaphors, talk with one another about that too, what you're finding works, because we're all doing the same work and we're all trying to like make it easier for ourselves. And you guys as peer supports with one another, share that. You know, the other big one I utilize all the time, no matter where I'm at, and it's so weird because I've been, you know, born and raised here, landlocked, but I always talk about a ship with holes in it. And this is like basically with anything in life. If you power ahead with the holes in that ship, the ship will sink. You gotta fix the holes before you keep going. That's my metaphor for work, for life, for friendships, for family. Like, you gotta work on those holes if you're gonna power forward, you know? I use that in counseling too. We gotta plug up some of the holes, whatever they are, you know, use, family stuff, relationship stuff, if we wanna keep going down the river, the lake, or whatever, which is really funny, cause
There's no water.
there's no water around here, but
We got
Abbey Coupon. I've even sometimes for, in this area talked about, you know, they do whitewater rafting down, right up here,
The Rio Grande.
down the Rio Grande. I'll even say it like that, like if you got into that, raft, and there were holes in it, you probably wanna jump in that river, and guess what? The river is gonna get windy, it's gonna get rough, you know, nobody's guaranteeing you safe travels ahead. Make sure all the holes are patched before you get going, right? So that's what I have for you guys today. I encourage you to utilize those and share with one another. If you're finding something that really works here, keep building on that, okay? And we'll probably talk later more about like Dan and his mountain metaphor. Maybe, you know, Maurice, try that. See how it flows
Yeah.
for you, or
like
the
it, like all of them.
pathways and the trails. Christina, you could try that out too if you know, are talking about, you know, building new thoughts and new pathways. I really like all of those, so thank you guys.
Thank you.